everybody. I am Candy Hansen from Superior Health Quality Alliance, and I am here to welcome you to the Organizational Initiatives to Reduce Patient Harm from Opioids series. And this series is session 4, Safe Transitions for Patients Taking Medications for Opioid Use Disorder. Next slide. So today's agenda will begin with introductions. Who is Superior Health Quality Alliance, or Superior Health? We'll do an overview of the webinar series, and then you'll hear the presentations, Safe Transitions for Patients Taking Medications for Opioid Use Disorder. And then we will walk you through a quality tool assignment and a sustainment checklist, and we'll talk about next steps. Next slide. So if you wouldn't mind, if you would put the following information in chat: your name, your role, your organization, your state, and then as an added bonus, what is your favorite holiday and why? And Yvonne, are you going to put that in chat so people can see it?
I sure, can you hear me?
Yep.
I sure will.
Thank you so much. So as people are completing that, let's just go ahead. Yvonne will put that information so you know what we're asking of you in the chat itself. Today we had 82 people registered for this session. We had states 11 from Michigan, 52 from Minnesota, and 19 from Wisconsin. And the facilities representative has stayed pretty consistent with 45 hospitals, 35 nursing homes, and 2 clinics. Next slide. So here is our Superior Health team. As you can see, there's a rather large group of us who have been working to work to put this series on. Today, you will be hearing from Rachel Dibble and Tracy Radke, and I will give you their bios in just a minute. So our team of quality improvement experts, we have 3 quality improvement organizations: Improve Health in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin. We also have 4 hospital associations, as you can see there, as well as the end-stage renal disease network for the Midwest Kidney Network. So we have hospital associations from Illinois, Michigan, Minnesota, and Wisconsin. Next slide. Here is our series schedule, and as you can see, we are already on the second to the last session. I just wanted to point out that we had to move the November session from November 12th to November 5th. So please make a note of that. That's just a week earlier. So just want to make sure you all have the right date for that last session, because Dr. Redwood is going to be coming back and being a part of our presentation team. So next slide. So the objectives for our series are to identify organizational opportunities to reduce harm caused by opioids, describe alternatives to opioids for treating pain, learn best practices in opioid prescribing and stewardship, describe stigmatizing language and its impact on patients seeking treatment for opioid use disorder, and identify practices not necessary to ensure safe transitions for patients taking medications for opioid use disorder. Our expectations over the course have been, you'll be encouraged to identify an improvement project, use and complete the quality improvement tools that we are making available to you, join the learning webinars, participate in coaching calls, and then sign the light for the personal pledge for Shine a Light on Stigma, which we'll talk about at the very end. All right, so I'm going to introduce our speakers, Rachel and Tracy. And so Rachel Dibble holds a master and doctorate degrees in nursing. She specializes in adult primary care and geriatrics with 20 years of experience. Her professional background includes quality assurance, clinical operations, hospice, and palliative care for many healthcare settings, including long-term and short-term care, assisted living, hospitals, communities, and clinics. She works for Superior Health Alliance as a subject matter expert and a quality advisor for medication safety and chronic disease management. Her experience in pain management within these settings has given her a breadth of knowledge regarding the patient population with substance use disorder or opioid use disorder, requiring treatment with medications for opioid use disorder. Tracy Radke holds a master's degree in healthcare administration and is a certified professional in healthcare quality. And sorry about that, as a Lean Six Sigma green belt with over 30 years experience working with nursing homes, clinics, and hospitals to improve quality and safety. She is a quality improvement advisor for Superior Health Quality Alliance, working with nursing homes and hospitals. For the past 5 years, Tracy has managed several opioid grants with the Minnesota Department of Health and Human Services. The most recent involves training rural providers on medications for OUD and alternatives to opioids, or ALTO. Rachel?
Thank you so much, Candy. I just want to make sure everyone can hear me. Just a nod. Thank you so much. Okay. So the session objectives today are understand addiction and medications to treat opioid use disorder, also known as OUD, identify and respond to the organization's readiness to care for patients on medications for opioid use disorder, and that acronym is MOUD, and understand the key elements for a safe transition of patients treated with MOUD. Next slide, please. So the overview of this session is the path to receiving and caring for patients on medications for opioid use disorder. So what we need to do is understand opioid use disorder and MOUD, meaning this is a substance, which is opioids, not potentially other substances. This is particular for opioid use disorder and the medications. Assessing and addressing readiness. So this is also organizational culture, meaning with staff, and just how the culture, mission, and vision statements are set up in your facilities to embrace and educate, particularly staff administering MOUD and understanding the transitions of care. Workflow, policies, and processes within your IDT meeting for these patients, and workforce development within the realm of MOUD. So key steps and strategies in the transition of care for patients on MOUD will be also in this presentation. Next slide, please. Opioid use disorder and treatment medications. So I show this slide because I think it is interesting to see the 3 definitions for opioid use disorder. And as we know, it really splits between mental health and medical or clinical, if you will. And this is what's really coming to light in the literature, understanding the behaviors and behavior change, coupled with the fact that it is a chronic disease. Opioid use disorder, I'll say it again, is a chronic disease that affects you medically as well. So it's refreshing to see that the needle is going that way. However, these are the 3 different definitions, and this is from the DSM-5, Yale, and Johns Hopkins. So what I want to point out is that the DSM-5 does note that this is a chronic disorder with serious potential consequences, including disability, relapses, and death. So what's interesting to me is that it is a chronic disorder, but we just really talk about disability, relapses, and death. We don't talk about organs, for example, and what happens potentially with this patient population. Yale defines as opioid use disorder is a chronic disease of the brain, sometimes called an addiction. So Yale is using potentially less stigmatizing language and addressing this as a disease of the brain. So we're bringing an organ into it. So this is good news for us. And so it's characterized by the persistent use of opioids despite harmful consequences. So we keep doing the same behaviors because we have a chronic disease of the brain that are not potentially productive for our lives. Johns Hopkins defines it as opioid use disorder is a complex medical So we've got chronic disease. Now we have a complex medical illness characterized by compulsive, so we're in the mental health world, use of opioid drugs. Even when using the drugs negatively, affects the person's physical, so we're getting into the body, and emotional. So Johns Hopkins is really hitting both of those two topics, mental health and clinical. So I'm happy to see that it is out there and that the needle's changing to chronic disease opposed to just, substance abuse, addiction, those sorts of words. Next slide, please. So quickly, the pathophysiology, and this hopefully will connect the dots and why this is a chronic disease of the brain, an organ, medical as well, right? The brain is mental health and organ. So our opioid receptors, they are located in the brain, spinal cord, and gut. So in the brain, that's why people do die of overdoses, because the excessive effect on the brain, your brain obviously regulates your respiratory rate. So if you have too many opioids in your system, your respiratory rate is going to go down. And then what happens? Death. So medications for opioid use disorder. So here we are getting into the MOUD, which is really what this talk is about. So there are 4 FDA has approved. Buprenorphine. Sorry. Yes.
Oh, I'm sorry. We're on the
I'm so
wrong
sorry.
screen. I think
I
we're on the wrong.
apologize. I
Okay,
apologize. Polling question. I'm so sorry. I was reading
that's
my
all right.
notes. I apologize.
I thought maybe we were on the wrong slide. Anyway, so we have a polling question for everyone. What percent of those with opioid use disorder are receiving medications to treat it? Is it 10%, 25%, 35%, or 45%? So click your answer and submit. Wow, yeah. So 80% of you think it's 10%, and then 10 and 10 for 25 and 35. So let's go to the next slide. So for those of you that said 25%, you are correct. In 2022, among the 4% of US adults who needed opioid use disorder treatment, only 25% of them received the recommended medications. And within that population, the highest percentage based on race and ethnicity was white, as compared to Black or African American, Hispanic, or Latino. Also, there were more men than women, and the largest age category was 35 to 49 years. So, in other words, if you are a white male between the ages of 35 and 49, you have the greatest chance of getting treatment. But before we move on, I want to tell you that those that said 10% are not wrong if we were looking back like 1 or 2 years ago. With the change in the DEA's requirement of this X waiver, there are a lot less barriers for providers in primary care to offer this service. So made a lot of improvements in that area. Next slide. So this is a poll that was done in 2023. It is of rural hospitals, so keep that in mind. And it is, the participants are participating in a HRSA grant, opioid grant. So of course, they're going to have hopefully more open ideas about opioid use disorder, but still interesting results. Anyway, so the 3 that I would like to point out is the preferred or non-preferred. So in the non-preferred, medication-assisted treatment, and that is still pretty commonly used, but the preferred language is medications for opioid use disorder. So I know the percentages don't add up to 100, which tells me that there are several providers who are using these terms interchangeably. The next one is substance abuse. That is not the correct language or preferred language. We should be using substance use disorder or substance misuse. And then the recovering addict. Just the word addict has all kinds of negative connotations, but we should be speaking in using our person-centered language of a person in recovery. And if we just keep focused on what is person-centered language, you'll not stray. Next slide. So before we can accept patients on medications for opioid use disorder, we need to understand if we're prepared to receive them and care for them. Next slide. So there are several readiness assessments that are out there. And I just looked at several different, and there's some links to those at the end of the presentation. But these are the top ones. First is board and leadership support. We're not going to get anywhere. We're not even going to get out of the gate unless we have the board and senior leadership supporting it through resources such as staffing, supplies, any equipment. We need that in order to provide the service. Infrastructure. So if you are already providing patient care, resident care, you should have these infrastructures in place. And they are to just in the background, keeping the business going, the supports and services that are needed to provide patient care. Financial feasibility. If the cost far outweigh the reimbursement for this care, then there's no reason to move forward, but you want to know that before you dive in. Regulatory requirements. You would want to check with your state to find out if they have any requirements, specifically in the nursing home for providing or treating certain conditions or prescribing or giving these medications that Rachel mentioned earlier. The big one is this knowledge and attitudes toward addiction. It's been a long-standing stigma that's been out there. And we have, junkie, you're a junkie, and it's seen as very, very negative. You're weak. It's all about willpower. So we have to get past those. And the best way to start doing that is through education and training. Next slide. Developing that criteria for admission and for discharge. So we're talking about your scope of care. What type of patient on MOUD can you take and provide and meet their needs? Workforce resources. You're going to need nursing who knows about addiction, a pharmacist who understands these medications. You'll have to have, if not internally, consulted mental health, addiction specialists, and a physician who understands MOUD. Operational systems and workflows. So what is different in this care that you're providing? The biggest of which is the medication itself. So are there going to be different workflows for admitting a patient on MOUD versus another patient or resident? And what does that entail? Do there need to be certain steps in place to prevent diversion, that type of thing. And that leads into your policies and procedures. These are kind of the foundational, though they're used to set the protocols and the expectations for care. And you'll also want to have agreements with outside specialists, community-based treatment, OTPs, those that provide MOUD, and then community resources, developing those partnerships between different organizations that can either provide this in the community when the patient is discharged, or can be utilized to support the care given in the nursing home or hospital. Next slide. Organizational culture and buy-in. This goes back to feelings, attitudes toward addiction. We talked about leadership support, and they are the ones that should be walking out the purpose of this service, the importance of it. They should be the role models, examples that support it. They should be setting the environment for this change and additional service. And that leads to the culture. Culture is kind of a big animal, and to me, it's everything. It's all the senses. It's a sense that you have when you walk in, whether there's a feeling of acceptance or judgment, whether this person truly cares about me and my recovery versus not. So it's all of those shared attitudes, values, goals, and are characterizing, that characterizes our organization. So it's bigger than just an ideal. It's the whole environment. MOUD stigma, that we addressed a little bit earlier, but you need to be specific and purposeful in how you're going to address that. The North Star framework or principle, and this you'll see a lot when it comes to product development, but it certainly has applications in healthcare. So it's that unwavering, unchangeable mission, vision, or ideal. It is what all things are measured by. And it builds culture because it's team-based. We do things together as a team. It's not top-down. We clearly share information. We're transparent in providing open and clear communication between teams and within the organization. We share our concerns. It should be a safe place where anyone, whether they're the CEO or the maintenance person or the dietary aide, that they can speak up on what concerns them and what they feel needs to change. And then lastly, mission, vision, values. These all tie in if you think about it. So the stakeholders or influencers, the culture, and that should all tie in to what your mission is. So anyway, I will now hand it over to Rachel for the next slide.
Thank you, Tracy. So in the vein of what Tracy has already gone over, this slide is about building community partnerships. And in this patient population, I cannot overemphasize the importance of this because we're dealing with medications. Potentially we're dealing with, if the patient doesn't get the medications, we're potentially dealing with them going back to their substance. So again, proactive care, build partnerships. So opioid treatment programs, or OTP. clinics and specialists. So particularly in your transitions of care, or if you have to go to an outside consult for particularly addiction medicine. So having those referrals and those clinics top of mind and created within your processes is imperative, because that's where you're going to get the treatments and the guidance. Clinics that provide MOUD, you should have a short list of who it is, so that you don't have to look when you do admit that patient, for example. Inpatient and intensive outpatient addiction programs, again, do an environmental scan or survey and see what is in your community. There's tons of resources and support out there. And support groups, again, another resource for the patient if they're out in the community to have access to care. It's the same mentality of access to care. That would be a support group. Peer coaches. One of the most profound impacts is potentially to have a family member talk about opioid use disorder or recovery. These talks are absolutely heart-wrenching. Some of them are celebratory with wonderful success stories. But at the end of the day, it is relatable for the audience and the person potentially suffering. So peer coaching, support groups, patient family facing, and their talks, super helpful to that person. Mental health specialists, oftentimes we do have other mental health issues going on as well. It is imperative that they are treated for a baseline if there are psychiatric issues, in addition to that MOUD, to address the OUD. And then public health county services. Your health department, actually, they're a great place to start to look for some of these resources, but have them available so that, again, it is easy. The barriers aren't there to impact the use of MOUD. Next slide, please. So develop workflows and processes. Again, use what Tracy said in the last couple of slides, but the developmental stages, policies, protocols, process, workflows. This is a huge animal to get underway. Bite-sized pieces is always helpful. So when you're thinking about this process, for example, think about all the pieces that go into what you're going to have to develop, create, build. So for example, you may have to have a pre-screening and an assessment, potentially on admission, approval to admit if the patient is already on MOUD, admission intake and assessment. Again, is the patient on MOUD or just maybe has OUD and then needs a psych consult and addiction medicine consult. So that's a good example of that. Communication with key partners, cannot overemphasize this. It literally is like a bicycle wheel with all the spokes. That is your communication between, if they're coming from the hospital, the ER docs, then maybe the attending on the floor, then the discharge, the social worker, making sure they have the resources. Where are they going to get the medication? How is the process to get the medication to the patient going to happen safely? So those are all the things that need to be thought about when you develop policies, protocols, processes, and workflows. So again, treating patients with MOUD, we need provider oversight, medication management, timely medication administration through the correct route is so important for these patients. Diversion prevention, documentation. If you don't write it down, it didn't happen. And with these patients, it is particularly important that you write in detail, write down the time, particularly the time of medications being given. And then respond to an overdose. That's a part of it too. It could happen. So create a process map showing the steps in the transition of patient residents on MOUD. So just through all of that jargon that I just said, we can see that this process is extraordinarily complex. And each bucket, if you will, has to be broken down with the policy, with the process, with the workflow. So that's where you need your leadership, your stakeholders, the budget needs to be in order, etc., to set up a plan. So this would be an example. Next slide, please. I'm sorry. Thank you. So this would be an example of the transition process. So this would be something that your workflow map might look like, or you're just ideating and you're throwing things against the wall to see what could work, what resources you do have. So the first example is hospital to long-term care facility. So again, we have the same steps, hospital discharge, referral to OUD and or SUD to an outpatient clinic as appropriate. Again, then you have to complete the admission process, the assessment process, the med rec process, then your hard copies to give to the patient and give to, for example, the long-term nursing home. Long-term nursing home to the community. This is much more complex because they need outside resources like support groups, for example. So again, you can see this scheduling appointments before they leave your site, really important. We need to determine the resident's home status. So when we discharge them, we have to think of housing, we have to think of food, we have to think of transport with this patient. It's a chronic disease. So just like someone on dialysis, we would have to think about these things too. So it's this apples to apples. We need to determine if the patient has anyone at home who can help this person. If they have anything, again, then the med list, the hard copies. And then we want to always connect telemed, telehealth. How are you doing? Check in on these patients. Next slide, please. So the naloxone emergency kit is really essential, and you can save a life. Absolutely. You have this available, have it in your purse if you're just in the world at large. So you can purchase ready-made kits or create your own. They include naloxone nasal spray, gloves, prevention items like fentanyl, test strips, which is wonderful to know as well. The other piece to this is to train your staff and patients and families, caregivers on how to use it. It's great that they have it, but if they don't know how to use it, then we've lost a life. And this medication, naloxone, completely benign. Even if they haven't overdosed, it doesn't matter. It won't hurt them. So err on the side of caution. Have these kits readily available. Create a process around these kits. Where are they? Where are they stored? Are they safe? Is the expiration date correct? If there is one, et cetera, et cetera. And then ongoing training to your new staff. This is where the kits are. If you think an overdose may be happening. This is classified now as not an epidemic, but a pandemic. So this will probably be part of our daily lives more and more as time goes on. Next slide, please. So again, training and workforce development, develop content for staff onboarding and annual education. So back to your processes and developing in your maps, for example. So we have to know that addiction is a chronic disease. We know that medications for OUD and stages of MOUD, stigma. So all the things that we thought of before, we need to just kind of clean slate it and think of it as a chronic disease. The addict, the junkie, those words need to go away and are on the decline. So we need to recognize who someone is going through withdrawal or an overdose because we have our naloxone and we can save a life. Medication management for MOUD, including, again, storing, disposing, all of the safety measures that we need to do to ensure this medication is available and safe. And then managing pain. You still maybe have to manage pain with folks on MOUD. So that's something to be aware of. Validate competencies within your workforce. There should probably be an annual training just on OUD and MOUD would be a suggestion. Again, there's many resources out there, training modules, toolkits, how to build these sorts of programs. So I encourage you heavily to do so. Next slide, please.
All right, thank you, Rachel. Now we're going to move into transitions, right? The purpose of today is to learn about what are some of the key things to keep in mind and strategies. Next slide. So I'd like to share a little information as we go along. So we have another national study, also done in 2023. It was a study of community health needs assessments reports of nonprofit hospitals, which the majority are considered nonprofit. And they found that only 17% of these hospitals offered acute care interventions to support a patient's transition to community-based addiction services. So, and that could be, so on the inpatient side, or even the ED, they were not given treatment options or a referral, and so on. Next slide. So here are some strategies within the emergency department. Hang on, sorry. Start the induction if they're not already taking those medications. They do have to be experiencing withdrawal at the time. And you can discuss other treatment options if they're not willing to start those medications. Any patient that is, has a substance use disorder may have additional needs. And it's important to recognize those and to offer those or get them connected with the services they need. And you want to give them that free naloxone. Huge, huge, especially if they've come in with an overdose. You want to get that in as many hands as possible. And if they have decided to go on these medications, then you want to give them that bridge medication, meaning that prescription that will carry them over until they can be seen in a clinic for further treatment. Post-discharge from the ED, you want to schedule their appointment with the provider. It really is important because you don't want to take the risk that they're not going to follow through. So do as much as you can for them. Do a phone call as a follow-up. How are you doing? Is there anything that's going to keep you from getting to your appointment? And again, making sure they're connected with the services they need, including support groups. And there are a lot of community resources that we'll show later on. Next slide. If you're transitioning from the hospital to a nursing home, the hospital needs to make sure that that they have somebody consult if the hospitalist isn't familiar with MOUD to make that recommendation of where that patient should go. Of course, with any patient, you reconcile their meds. You want to make sure that you have an accurate reflection of what they are taking. And provide or refer them to the right long-term care provider if that's where they need to go, who can offer the services that patient needs. In that referral, you have to clearly document, the hospital should be documenting when the patient was inducted and what medications they were given. When they are sent the referral to the long-term care, opioid use disorder can never be the primary. It needs to be secondary. Make sure that the release of information includes treatment records. These have a higher standard of protection. Hospital should be medicating that patient with the dose that they need until they can get their next dose at the nursing home. So please confirm with the nursing home the date, the time, and the dose they were last given. And discharge instructions should be sent with the patient. Next slide. On the long-term care side, be sure you perform that pre-admission screening, make sure you can meet the needs of that patient. If you already have a contracted provider to oversee their medications for opioid use disorder, let that hospital know that that will not be needed. Request that they clearly document the date of the induction, as well as the date, time, and last dose given. If they do need a provider, be sure to make that connection or referral. Verify medications and prescribe naloxone as needed for overdose or apnea. Next slide. I will now turn it over to Rachel.
Thank you. So as Tracy has talked about a lot of the transition strategies, this is the last one insofar as the inpatient stay to the community. And like I mentioned before, there are a lot more variables when the patient goes back into the community. So again, prior to discharge, discuss treatment options and plan with the patient. Again, have that motivational interviewing idea and technique going with these conversations with this patient population. Link to treatment. Schedule an appointment with MOUD and outpatient clinics or specialists as well. Give warm handoffs. The patient needs, they do better when they have something in their hand. So opposed to I'll make the referral and someone will call you, potentially call right then and there and leave a message if you need to leave a message, so that the patient knows that contact has been made and you know contact has been made. Identify any essential needs. Example, Tracy talked about it too. Transportation, food, housing. It's imperative for these patients. And then based on their needs, again, ask open-ended questions. What do you need? How can we help you be successful? And they often, the patients just want to talk, and you will glean information from them and then connect them with the appropriate agencies and programs for their community support. So continued to the day of discharge, again, print the discharge. They do, again, everyone does better with handing tactile things in their hands. And also talk about it. Provide the education about their bridge medication prescriptions, really, really important, meaning don't miss a dose would be the takeaway there. And that education of why behind that would be helpful for that patient, and give them the support that they need to continue with the MOUD treatments. Send medical records to all of the referrals if you're making them. Again, please, when you refer, just don't refer and forget about think the patient's going to take it. Follow up with that patient, support that patient. One phone call means a lot to that patient. Again, your bridge prescription, send them to the pharmacy of choice. Just make it just practice. Hand a free naloxone kit if you have one. If not, maybe look at your organization and see if you can build a MOUD naloxone program. Reconcile your medications. Provide a packet with the key items, such as a crisis lines. They have to have somewhere to call. Details of appointments, again, handwritten. Spend some time on this to support this patient. Transportation voucher services and community services. So these are all the things for this patient going into the community that they will need. If not at that moment, in the future they will. So being proactive with these patients is helpful. Next slide, please. Transition strategies in patient stay to the community continued. So this is the third slide because there's so much more to think about for that patient going into the community. Again, send referrals and medical records to specialists. Follow up. I will overemphasize that. Texts, any kind of contact with this patient. That is often all they need to keep on the course. Care navigation, again, some of these folks will not have a lot of resources, maybe don't even have a cell phone, so they need access to services. So your open-ended questions will help you with what they have and what they don't have. Next slide, please. So we will conclude our talk. Tracy and I thoroughly enjoyed it, and I would like to offer, if anyone has any questions, please put them in the chat. Open conversation here with any kind of questions you may have. We'll give you a couple minutes here.
And then let's move along for time's sake. You can interrupt me at any time if you have a question. You can use the raise the hand, or you can put it in chat. So the next step, if this is what you choose to do, is to convene a project team, utilizing the tools that we've covered or tools that you already are using that you find helpful. And those are the charter, the desired performance statement, the action plan, implementation strategies, and on to the next, our final tool. Next slide, is the sustainment checklist. Next slide. So the sustainment checklist, it's an ARC tool that they no longer share. I was lucky to find it before they discontinued because I love checklists. I always feel like I'm accomplishing. But anyway, 4 key areas to sustain this work. You work so hard to do. You do not want to slip back into old habits or forget a critical part of the process. So leadership, sustainability. You want to make sure that they will continue to give you the resources that you need, such as if a staff person leaves, replace them, the supplies or equipment. The next area is workflow processes and support. So it's critical to hardwire the daily workflow. And how are you going to do that? How will you address any challenges that come up? Do you have a strategy for quality improvement, such as the PDSA, to redesign your practices? And then our desired results, are they being reinforced, and how? Sometimes when a project ends, we think, oh, we're done. You know, we don't need to tell staff how much we appreciate the great work we're doing. We don't need to reward success. But yes, you do. And so put a plan together of how you're going to do that. Education. This one hopefully is the easiest because it should fit into your onboarding education and any annual training that you do. Monitoring sustainability. So is there a committee or a team that will be assigned to monitor the key metrics that you've identified? And it may not be the same ones you use during the project. It could be something else. And is there a strategy in place for evaluating those metrics and evaluating the data to determine when change is needed? So those are the 4. And then this next slide is a picture of this, again, is an ARC tool on monitoring progress to sustain improvement. And this is a tool that's used with their quality metrics, but it still holds a lot of value. It'll give you information on an overview and the rationale for monitoring, help you identify key elements of the monitoring system. So essentially, it'll walk you through if you're not sure on how to structure it. Next slide. Community resources. Next slide. So your state has a phenomenal number of resources for your patients, for this population, and be sure to check them out. Next slide is Minnesota. And some of these services will provide a navigator, a care navigator for somebody in recovery. will hook them up with all the services they need. Next slide. And here are those in Wisconsin. So if you are not familiar with the resources available to you, please be sure to pull these up. Next slide. And then these last slides, keep going, are the general resources that we mentioned throughout the presentation. Next slide. More, next slide. And then here are the references. This is where we pulled our content for the presentation. So next slide. Next slide. Next steps. All right, next steps. Next slide. We want to hear from you. Please, please, please. It's how we do better in sharing information that you find pertinent and valuable. So this is a link to that. Next slide. We have a coaching call coming up on October 22nd. There's a link here to register. This is a great time to talk through maybe what you've decided on for a project and help you maybe frame it up. Next slide. And then we have one final webinar on November. This is actually wrong. It's November 5th. And that is going to be given by Dr. Bobby Redwood and Rachel again. Next slide. Please be sure, if you haven't already, take the pledge on Shine a Light on Stigma and learn more about it and its impact. And I cannot let you go without sharing this. So October is Substance Use Prevention Month. And this link to SAMHSA includes a ton of information, ways that you can promote and recognize this. Next slide. If you have any questions, please reach out to Jenny or myself. Nursing homes can reach out to Candy and Yvonne, and Rachel will take any other setting or any of your questions. Next slide. So that is the presentation for today. Are there any questions?
There are no questions in chat.
How many of you are already, if you're in the hospital, are you inducting patients that are inpatient? Are you inducting those in the ED nursing homes? Are you taking patients on these medications? I would be just curious to know if you're providing the service. Well, nothing in the chat. Oh,
Jennifer said most of their patients are transferred.
okay. Okay, good to know. Yeah. All right. Well, thank you all for your time and joining us today. Please reach out. We will send you a follow-up email with important links, the slides, and the recording. Have a great day.
Thanks, everybody.